Hello and welcome. The topic of this video is hypercalcemia and hypocalcemia. How does the body maintain a normal calcium level? Endocrinology works through a feedback mechanism, which starts with an optimal range for any biologic function. This is called the dynamic range. And within this dynamic range, there is an optimal set point. For calcium, the dynamic range is from 9 to 10 milligrams per deciliter, and the usual set point is 9.7. Note that this is bound calcium. Calcium is 40% bound to albumin and also bound to anions, so that the active portion is the free portion, which is only about 40% of the serum calcium measured. This is mostly determined by the pH level of the blood, so that in measuring total calcium, one has to pay attention to what the serum albumin level is. To maintain this dynamic range, there must be a sensor, and in the body, this is the parathyroid gland with the calcium sensing receptor on the parathyroid cell. When this detects a decrease in calcium, it releases PTH, and it is the PTH that restores the calcium level. PTH does this through two organ systems. Through the bone, where it stimulates the PTH receptor on the osteoblast, producing osteoclasts that are going to dissolve bone to release both calcium and phosphorus. And it interacts at the level of the kidney, where in the proximal convoluted tubule, it's going to inhibit the sodium phosphate channel, and that will lead to a decrease in phosphorus, and it will upregulate the PTH receptor in the distal convoluted tubule, and there will be increased resorption of calcium. The presentation of hypercalcemia is well captured by the medical school mnemonic of bones, stones, abdominal moans, with psychic overtones. In clinical practice, however, the commonest cause of a hypercalcemia is going to be as a lab test, in which the calcium is greater than the usual lab reference range of 10.2 milligrams per deciliter. This is found in 80% of hypercalcemic cases in America. With symptomatic presentations, the most common cause, 10 to 20%, will be kidney stones. So while hypercalcemia is associated with kidney stones, note that less than 5% of kidney stones have hypercalcemia. The next commonest set of symptoms are neuropsychiatric, and these mostly consist of weakness and fatigue. GI complaints include pain, which is moving and vague, nausea and vomiting, and constipation. And last can be an insufficiency fracture due to the osteoporosis from sustained PTH. The three classic osteoporosis fractures are compression fracture of the vertebra, fracture of the hip, and then the Colles fracture of the distal radius. The physical exam is really non-contributory in hypercalcemia. When one has a patient with hypercalcemia, in America, 90% of all of the cases will be one of two causes. It will either be primary hyperparathyroidism or it will be cancer. Primary hyperparathyroidism is going to be an otherwise well 35 to 45-year-old woman with vague complaints, and the cancer patient will classically be inpatient with a known diagnosis. There are lots of exceptions to this, but that's a good way to think about it. Typically, the first thing ordered will be a PTH level. And if that is increased, then the patient has a primary hyperparathyroidism. Note that 10% of these will have multiple endocrine neoplasia. If the PTH is decreased from the hypercalcemia, then the next logical test will be PTHRP. This is an embryologic form of PTH that's released by many of the carcinomas. If that is present, then the patient should be investigated for the underlying cancer. If it is negative, the next commonest cause in America will be due to vitamin D abnormalities. If that is increased, there are two common presentations. One is because it has been ingested, and this will be a vitamin D2, the commonest storage form. But if it is due to macrophages, because these have 1-alpha hydroxylase, then it will be a vitamin D3. And common causes of this are going to include granulomatous diseases like sarcoidosis. 10% of sarcoidosis patients will have an increase in vitamin D, and it will be vitamin D3 because it's from the 1-alpha hydroxylase. If the vitamin D levels are negative, then one is left with a list. This will include things like medications. The commonest medications for this will be thiazides and lithium. And we'll talk about those mechanisms later in the discussion. Hyperthyroidism can cause increased turnover of bone. And then there are specific types of cancers like multiple myeloma. If there is hypercalcemia, what are its effects on the patient? The first rule to note is the effects are due to duration of the hypercalcemia and not the absolute level. Certainly the symptoms that are going to be driven by long hypercalcemia are going to be an increase in kidney stones. There are the mental changes, and there are the GI complaints. But studies of large groups of people have suggested that long-standing hypercalcemia is associated with a decrease in lifespan. And as investigations have become easier, this is starting to push more aggressive approach to hypercalcemia. Most of the time, you'll start the investigation, and the commonest pattern will be an increased calcium and an increased PTH. And this is then going to be called primary hyperparathyroidism. What is one's approach going to be? Because the 75% that are caused by adenomas can be very difficult to find by imaging and physical exam, and leads to the question, does one do exploratory laparotomy? Note that primary hyperparathyroidism doesn't discuss what the underlying pathology is. The pathology can be an adenoma, which is the majority of cases, or it can be a carcinoma. This is one of the rare diseases that is defined by its lab diagnosis and not its pathologic diagnosis. With the development of minimally invasive surgery and this possibility that there's a decreased lifespan with chronic exposure to hypercalcemia, I think there's going to be a shift now from managing patients with low symptoms by expectancy to being a much more aggressive approach and looking for the adenomas and the hyperplasias. Over your career, you're going to see a change to exploratory surgery and a definition of the disease by pathology. 10% of adenomas are associated with multiple endocrine neoplasia type 1. This is an autosomal dominant disease, so family history is an important part of all hypercalcemia workups. Malignancy and hypercalcemia is a late event. So the underlying cancer is usually known. In aggressive carcinomas, it is seen in about 25% of cases. There are three basic mechanisms by which a cancer can cause hypercalcemia. The commonest, 80% of the time, is going to be the production of PTHRP. Note that this is going to be a tumor that does not have to have metastasized. It's actually secreted by the tumor itself. This is then going to affect the osteoblast by stimulating the PTH receptor. So that will give an increase in calcium and a decrease in phosphorus. But it does not stimulate the 1-alpha hydroxylase in the proximal convoluted tubule, so there tends to be no change in vitamin D levels. Second common mechanism is in metastatic disease, in which there is local effect. And this is usually mediated by cytokines. The model disease for this is multiple myeloma. The third mechanism of hypercalcemia in neoplasm is the tumor itself secretes vitamin D, which increases GI absorption, and this is most commonly seen in lymphomas. Malignancy is the setting in which one is most likely to see severe hypercalcemia. This is defined as calcium greater than 13. And in this situation, there is the possibility of life-threatening coma, cardiac arrhythmias, and metastatic calcification, which predominantly occurs in blood vessels and can impair kidney function. The treatment for this is going to emphasize hydration, calcitonin, and bisphosphonates. Vitamin D toxicity can occur from two different pathways. Vitamin D can be ingested from the diet, or it can be formed from cholesterol in the skin, which is exposed to ultraviolet light. It will form cholecalciferol, which in the liver will be converted to 25-hydroxy vitamin D. This is the commonest storage form of vitamin D, and it has a low level of activity. If that vitamin D is exposed to the 1-alpha hydroxylase, then it will form 1,25-dihydroxy vitamin D, also called cholecalciferol. And this is the most active form that's going to affect the gut to increase resorption of calcium and phosphorus. The two ways of getting vitamin D toxicity is through the diet, which will mostly give us the storage form of 25-hydroxy vitamin D, and from diseases that cause an increase in 1-alpha hydroxylase, which will give us cholecalciferol. And these are mostly diseases with an increase in macrophages, which is granulomatous diseases like sarcoidosis. 10% of your sarcoidosis will have hypercalcemia. Medications can cause hypercalcemia, and the two most important are thiazides, which act through an unknown mechanism. The hypercalcemia typically occurs late in patients that have been on the medication for more than 5 years. The second commonest medication is lithium. It acts by decreasing the sensitivity of the calcium sensing receptor so that it requires a higher level of calcium to trigger a PTH response. This decreased sensitivity of this receptor is very similar to the change in the receptor seen in familial hypocalciuric hypercalcemia. Hypocalcemia only presents symptomatically in an acute setting, because in a chronic setting, PTH will reestablish a normal serum calcium level. The symptoms in an acute setting start with perioral tingling, which then proceed into cramping and can end in seizures. On physical exam, there is Trousseau sign, in which a blood pressure cuff is inflated on the upper arm, resulting in carpopedal spasm of the hand. Dvořák sign consists of tapping the 7th cranial nerve on the face, which causes twitching of the facial muscles. In testing, one can order a serum calcium, but remember, it's the free calcium that is the bioactive element. If there is a low albumin, one can do a corrected calcium by having 0.8 times 4 minus the serum albumin. We will now discuss important diseases with hypocalcemia, and we will start with the 22q11ds syndrome. Note that this is reasonably common. You can see it in 1 in 4,000 births, and so it's now screened for routinely in America. And the way they screen for it is with cell-free DNA from the mother's serum. Non-invasive prenatal testing. Note that routine testing, even 5 years ago, was the so-called quad testing, quad for 4, of alpha-fetoprotein, beta-HCG, estriol, and inhibin P. And these were very good for the trisomies, especially trisomy 21, and any of the malformations that open the internal cavities of the body, which include spina bifida and the abdominal closure diseases. Ultrasound was really good for the cardiotruncal defects of the heart. But this has now been mostly supplanted by the non-invasive prenatal testing, which will detect the trisomies and any of the chromosomal deletions, and then a huge complex of all the variations we see. But note that it's not going to be good for the malformations. Pathophysiologically, the 22q11ds portion of the chromosome has about 30 diseases, and this controls the formation of the pharyngeal arches. And when that abnormality forms off the third and especially the fourth arch, this is going to regulate the following organs. More than 60% of the 22q11ds patients will have parathyroid gland agenesis, and these babies will be born with hypocalcemia. When the thymus produces less than 1% of the normal number of T lymphocytes, this will give a severe combined immunodeficiency syndrome called the DiGeorge syndrome, and these patients will present with sinopulmonary infections. Over 80% of these patients will have tetralogy of Fallot, and they have abnormal formation of the face, which is elongated, has low ears, and other abnormalities, the so-called velocardiofacial disease. 22q11ds is an important inherited abnormality that affects a wide-ranging number of organs formed off the pharyngeal arches, particularly 3 and 4. Parathyroid glands sit on the posterior aspect of the thyroid, and when one is doing a total thyroidectomy, typically as a cancer operation, you have to identify the thyroids to make sure that you have not removed all 4 of them. If the procedure goes poorly, and you do, post-op day 1 will have a patient that is going to start showing the symptoms of a decreased calcium. So that will start with circumoral tingling, go on to cramping, and ultimately seizures. On the EKG, there will be an increase in the QT interval. And if this is severe, meaning it's more than 13, you're going to actually have to treat by giving IV calcium gluconate. And after that, it's a chronic support of vitamin D ingestion and oral calcium supplementation. Hypovitaminosis D in children is rickets, and in adults, osteomalacia. In modern economies, most of the food has vitamin D supplements, so this is quite uncommon to see now, and it really only occurs in selected groups. One can suspect vitamin D deficiency in the elderly. This is due not only to generally poor diets, but also decreased synthesis from the skin. In the winter, in normal climates, one can generally see vitamin D deficiency in about 1/3 of the population, just because there isn't enough sunlight to create vitamin D from the skin. Chronic renal failure loses function in the proximal convoluted tubule, and so there's a lack of 1-alpha hydroxylase formation. With malabsorption, there's a general inability to absorb any of the fat-soluble vitamins, A, D, K, and E. And then in severe cirrhosis, there can be a failure of the formation of 25-hydroxyvitamin D. Patients with pseudohypoparathyroidism have a defect in the PTH receptor, found in the distal convoluted tubule, and it is a GS-alpha receptor. The GS-alpha fragment is going to stimulate adenyl cyclase by adding a GTP. This then produces cyclic AMP, which activates pKa. pKa upregulates the calcium channel in the luminal side. This calcium is then returned into the blood, both through a sodium-calcium exchanger and through a minor calcium ATPase. Patients with pseudohypoparathyroidism do not get the signal between the GS-alpha and the adenyl cyclase. A test is to give the patient PTH and show that there is no cyclic AMP production in the urine. These patients have a highly variable presentation, but typically they are short, obese, they have a round face, they have developmental delay, and they have this very curious finding in the hand in which there is a decrease in the formation of the fourth metacarpal. And one can see what that would look like. Here's the fourth metacarpal here, and it is short. And when the person makes a fist, it doesn't form evenly across, and that is a characteristic dimple sign. In lab testing, there is a hypocalcemia, increase in PTH, and an increase in phosphorus. Other glands are commonly affected in this. The thyroid, with poor response to the TSH, the gonads, with decreased response to FSH and LH, and the pituitary, in which there's a decreased response to gonadotropin-releasing hormone. The treatment is one really of trying to reestablish normal calcemia. And so chronically, this is the usual oral calcium and vitamin D supplements. Some people have found use with calcitriol. And then because they're small, they're often given growth hormone for size. Hypocalcemia is seen in acute pancreatitis. The pancreas releases 3 families of enzymes for digestion. There's amylase for carbohydrates, that breaks the starches into disaccharides, proteases for digestion, and in the pancreas, this is what causes the liquefactive necrosis. The lipase acts on triglycerides, which are formed from a glycerol backbone with fatty acids through the oxygen bond. And lipase fractures that bond, and so it leaves free fatty acids, which are going to have the free oxygen site. And this combined to metals, and when that metal is calcium, it is going to form soaps. These calcium salts have physical-chemical properties that result in soaps. But the binding of the calcium is going to decrease the serum calcium. In any patient with acute pancreatitis, one must monitor the serum calcium levels. The serum calcium levels do correlate with the severity of the acute pancreatitis. They drop in 80% of severe disease and 40% of mild disease. So they are in part a prognostic factor. Magnesium is important for the absorption of calcium. The two are quite related in the kidney. Hypomagnesemia is mostly seen in hospital patients. And these either lose their calcium through GI mechanisms, and just as one would expect, this is diarrhea, which is more common than vomiting, or through the kidney. And these are more complex mechanisms, usually related to medications like diuretics or medications that are renal toxic. Magnesium can be restored, typically by oral ingestion. We finish with the discussion of chronic renal failure. Progressive chronic renal failure goes through stages that are classified according to the GFR. And in chronic kidney disease, by stage 2, which would be less than 90 milliliters per minute, the first abnormalities show up in the sodium-phosphorus channel. This is found in the proximal convoluted tubule and is important for regathering the phosphorus which has filtered. By stage 2, this is abnormal enough that too much of the phosphorus is reabsorbed. The body responds to this increase in phosphorus by increasing fibroblast growth factor 23 and PTH, because the phosphorus binds to the calcium, precipitating it and decreasing it. Your patient is still asymptomatic, but note the increased PTH is going to result in osteoporosis, and if it goes on long enough, osteitis, fibrosis cystica. By late stage 3, when the GFR is less than 30 to 40 milliliters per minute, even signaling by the increased parathyroid is inadequate to maintain homeostasis. And so one starts to see a rising phosphorus and a dropping calcium. And at this point, medical intervention is necessary for patient effects. In addition, because of the increasing damage to the proximal convoluted tubule, there is also a decreased level of vitamin D3 synthesis because there's no 1-alpha hydroxylase, and that also contributes to the low calcium status. So that brings us to the end of this discussion. Thank you for your attention. We look forward to seeing you next time.